Well, a great big thank you. Before I turn it over to you all, a very big thank you to all of our moderators and our speakers and our planning committee and our standing committee members for making this first day, this is just the first day, which really sets, I think, the landscape and the framework for what the committee has been trying to do. Now we want to hear from you. You can ask questions if you want, but really what we want to hear are your comments, what you're thinking about, what you've picked up today, what your concerns are. And I'd like to start with our sponsors. So just, signal, we'll bring you the microphone, stand up, tell us who you are, and what you're thinking. Now, we know that our sponsors have invested a lot to have us do this today, so we think you've probably got something to say. We've got a half hour, we'll wait. Party doesn't begin until 5:30. Okay, so while you're thinking about, I think the sponsors are kind of down here somewhere. While you're thinking about that, because I'll get back to you. Let's hear from the rest of you. Let's get you have a microphone there, right behind you. We've heard from you today, but please reintroduce yourself.
Roy Simpson, Vice President of Nursing for Cerner and faculty at Emory. My question comes in two areas. One is in regards to coded data sets or structured data sets, and the second one comes into fact of nursing's hostility to the marketplace, and yet all the credentialing is aligned with marketplace initiatives. So I'm really kind of a little confused there, but I'll get to that one second. The first one comes up in that Karen mentioned the 14 data sets that were recognized by ANA, but SNOMED only recognizes 2 of them and only has 1 in process, which is ICNP. It recognizes Sabacare and Omaha. So my question is, if ONC is recommending SNOMED CT for all of us in the world to be coding and pulling our abstracts to, why do we have 14 out there that we can't possibly collect our data that people need to collect when we collect through SNOMED? And I'm hoping that Patty Dykes is going to give some insight, but it's a very complicated issue for those of us who are in the industry, because we are constantly asked, do you collect so-and-so? And we say, well, that's not who the government and everybody has authorized to collect, so we can't just collect everybody's individual terminologies and taxonomies they use in their own institution. So I would hope that credentialing would help us move towards a standardized terminology and an adoption for collecting data about credentialing. And the second one is on the hostility of the market. How are we going to get nurses to say, credentialing's worth money and you'll pay me more because I'm better than everybody else?
Okay, I'm not
save that one for our sponsors.
But in terms of
somebody here's got to answer that.
That's right. So in terms of the data set, so my understanding is that, with meaningful use, we all have to use SNOMED, right? But SNOMED has mappings to all of the nursing terminologies that are currently maintained.
I don't want to argue, but Judy Warren has been very clear that NHTDSCO, whatever that group is.
So they're not maintaining them?
Which is part of WHO.
Right.
They only recognize Sabacare and Omaha, and then they are working for, which ICNP just sent out an email last week. Oh, I thought I was screaming loud enough into her mic. I was screaming in her face anyway. I thought that was the whole issue, because I know NANDA, NIC, and NOC are not through SNOMED. Now, their terms are in SNOMED, but not in ICD-10. So we lost them when we moved to the next level, and that's what my fear is that everybody's going to say to me, your clients don't have so-and-so, and I'm going to say, whoa.
And you'll say, show me the money, because someone's got to maintain the mappings. And so that's the problem, is with a lot of these other, like the CCC, I know that those mappings were done by CCC and the CCC board. And same with ICMP, they're doing the mapping. So they're actually doing the maintenance. So, if we're going to continue to develop these terminologies, we have to maintain the mappings to the standard, the U.S. standard, which is SNOMED.
And SNOMED has said that unless it's a public domain coded structure, they will not allow it to be in SNOMED. So we have to figure out a way to get our data into the public domain so that we can track it.
So I have a suggestion. Tomorrow, there's a work group on data. This is a perfect discussion to have there.
She got her doctorate in CCC, so I know that.
So there's one more question about this notion of sort of the market hostility and what nurses themselves might do about assuring that credentialing is valued and paid for and supported.
I mean, I thought the question that Sue Hassmiller, wherever she went, on the attitudes was really clear. I mean, we have to make, we've said it at our corporation that every nurse has the opportunity to get certified. We'll pay for it. We bring them in for boot camp. We do all the things that we're supposed to do. Some of them still aren't grasping that it's going to come down sooner or later. They're either certified or not, and I have to go get mine too, so I'm even anxious about it. But, you know, making such a statement. But it's very concerning to me that nurses in general, which is not a good thing to say to a researcher, I realize, but it's mentioned 3 times this afternoon about the marketplace. And the marketplace shares its capitalism based upon an economic exchange. And we need to figure out a way to make sure that people know that there's an economic exchange for that outcome that's better, whether it's insurance carriers or someone else. And we need to say, you need to pay me more.
So our sponsors are representatives of the credentialing community, the specialty community. Do any of you have an answer for Roy? I mean, what do you think about that? Please. We need the mic.
This question was asked at AONE when there was a presentation on structural empowerment, and Tim Porter O'Grady's response was, when you invite nurses to get credentialed, and you think about that from marketing theory, you get about 10% response rate. When you create the expectation that you as an employee of this organization will become credentialed once you qualify for a credential, that markedly increases the participation rate. So that, one of the persons in the audience stood up and talked about that. Good Sam and Marge Maurer, who's the CNO, said that that's exactly what they've done, and it has made a huge difference in participation and credentialing in their organization.
Let's start over here with Linda, and then,
So, you know, this is a difficult one. Both of you are right. So in my organization, you cannot get to a CN3 level without a bachelor's degree in certification. You just can't. And if you come in at a CN2 level and you don't have the number of years before you can sit for the certification exam, you get that many years to do it, and if you don't, then you're out. But I'm an academic medical center. You take the 400 and so hospitals in the state of California, there's less than 10 of us that are academic medical centers. And the costs, there are real costs to certification and keeping up the costs. So until we make it much more of everyone can afford it, not just the academic medical centers, and we start producing more and more evidence. So for us, for example, I use niche as an example. Well, it's not just having niche, it's the fact that we were able to demonstrate consistent 41% reduction in length of stay index. You reduce length of stay index, that reduces your total cost of care. You just keep making that business model. And what happens when you have 84% of your nurses certified, like I do, and you can tie it back to the business piece. That's what makes it, because that costs, because it costs us. There's a 3% salary differential for certification. On top, there's another 3% salary differential for a bachelor's and another 4% for a master's. It costs.
So Linda hit some of the key points that I'm the dyed-in-the-wool economist on the standing committee. So there are two problems. The first problem is that as long as hospitals are getting paid the same amount of money for producing mediocre care as they do for producing great care, we're going to get mediocre care. And so thank you, Dr. Kaiser, for believing that fee-for-service is dead or on its way out. I hope you were right, because that will finally create some financial incentive to care about quality. The second piece, and I think this is why we are here as a workshop, is we don't have a ton of evidence yet that the credentialing matters. There are believers like Linda. There are people who say, you know what, I don't care if I don't have all the evidence. I believe in my gut this is the right thing to do. And in an academic medical center, it's easier to make that belief and go out on that limb. But without that evidence, even if hospitals are getting paid more for great care, then they need to know that the credential is creating the additional skills or is a reliable signal that you're buying higher skills so that it's worth your investment. And then you'll pay more for it. Same thing for the bachelor's degree. Until you believe 100% that you're going to get better service or better work out of somebody with a bachelor's degree, you're not going to pay for the human capital. And, you know, that's the dour economist view. But I think those are two pieces that are missing. Is the fee-for-service is still, people believe that that's the way the world should work or is working still. And we don't have the body of evidence that we need to really convince all 450 hospitals in California and all 4,000 plus hospitals in the US that they should go there. So I'm hoping we get there at some point.
Yeah, there we go. And
Hi, my name's Linda Lactwall. I'm from Pittsburgh, Pennsylvania. I work for UPMC in Shadyside. I have two comments. First of all, I don't think that we introduce certification early enough. We need to introduce it more in the nursing schools, wherever the programs are. I'm adjunct faculty for 2 universities, and I ask all of my students, and I also teach in the nursing ed department at Shadyside Hospital. So I see certification and new nurses come in all different directions, at all different levels. And I ask them all, I say, do you know about certification? Do you know what that means? Do you know why it's important? I have not had one new nurse say that they knew what certification was. So I think that, one, we don't introduce it soon enough. If we make it flow seamlessly, that they get and they pass their NCLEX, then they become a new nurse. And after at least 2 years in that specialty department, then they become certified. It's an expectation. You know, we care for patients. They're humans, their lives, they're so valuable. You know, just finishing a degree, a 2-year degree, a 4-year degree is not enough. And through certification and credentialing, we can prove that. We can validate it. We need to tell them this is what they need to do. And then one other point to validate that certification does mean something, that I have a nurse in an outpatient area, ambulatory surgery. She got her CAPA credentials. And well, we're Magnet certified. We're up for redesignation. And Magnet questioned us as to, oh, this one story isn't good enough. You need to show more worth. You need to have better outcomes. And they came to me and they said, can you tell us a story? Linda, you got to have one story you can tell us. And I said, yes, I do. They wanted a nurse that was a bedside nurse that was actively involved in a national organization. And I said, it's Ursula. And Ursula is an older nurse. She became CAPA certified. And out of preparing for the certification exam, she practiced the ASBAN standards, and she incorporated that into the orientation. So she proved that the nurses that she taught through the ASBAN standards, that they practiced safer care, and they documented correctly in the electronic health record. So we pulled that data out, and we proved that the nurses who were not certified were not documenting correctly. So anyway, just really important, you know, simple evidence, the bedside nurse, and that's where we really need to congratulate and show that nurse their worth, because really, management is fantastic. They make the rules, but it's really the bedside nurse that validates, why we're all here today. And also, thank you so much for doing this workshop. It's phenomenal. Thank you.
Thank you. Over here.
I'm Patty Brennan. I'm not going to take Roy on. I want to let Lynn and Bobby know that I figured out why I'm here.
She told me at the beginning of the day she didn't know why she was here.
I'm here with a plea and a suggestion and a recommendation. And my plea is, we have so few skilled nurse researchers that if you want more research done, we need to leverage existing research. We need to find ways to partner with where our investments are. We are not going to develop a cadre of nurses separated only who can do research in certification and credentialing. So find ways to partner with people who are active and researchers. Secondly, my suggestion is, I missed most of the discussion about the conversation related to NINR's investments today, but I will tell you one thing, that if we can get into the agendas that matter with NINR, particularly end of life and symptom management, to explore where certification has actually accelerated either the creativity of nurses or the delivery of nurses, there will be a byproduct of the research that will provide some of the data that people are asking for. And the third thing is, I'm going to make a plea for Jack and for a couple of you, is Matt still here, who are teaching in schools of nursing, Jennifer, where we need just a small set, but a really skilled small set of advanced researchers, nurse researchers, who can tackle the parts of this question that are really needed, because we're not generally teaching this in our PhD programs. And so think about where our workforce development will come from. Thank you.
Thank you. We had a comment over here. Yep. Right behind you is the microphone.
Hi, Cindy Miller-Murphy with the Oncology Nursing Certification Corporation. And I want to say thank you to very impressive papers before and very good speakers today. Just to address the previous point, most nurses become certified for intrinsic reasons. I mean, all of our research shows us that that's why they become certified, for their own edification, to show their own professionalism. 50% of our nurses are not supported by their employers, at least in oncology. And that's why they do it. And the biggest barrier is fear of failure. And, it's not so much that they don't want to take that step. They're afraid of making the investment and not passing the exam. But by and large, nurses become certified, for the intrinsic value. So.
Thanks. We have someone over here.
My name is Kathy Kobler. I'm from the National Board for Certification of Hospice and Palliative Nurses. We are glad to be a sponsor of this event and thank all who are involved in this wonderful day of learning. One of the things that's been most on our board's mind, not only is that initial certification, but then how do we recertify? And we're hearing loud and clear from our certificants that financial constraints that organizations are facing, that employers are not willing to sponsor recertification. We're especially seeing this with all the shifts that are happening with reimbursement for hospice, and we're hearing it loud and clear from our hospice certificants. So I have not yet heard talk within everything that we covered today about recertification, but I hope that we can be paying attention to factors that impact that as well. Thank you.
Anybody else? Okay, well, it's not your last chance because tomorrow we'll have the breakout sessions, and in your packets are the list of those of you that are here and which work group you have. So that'll be a chance to really talk together about the content that you've heard, content that you will bring to the group, and really come up with your ideas about the questions that we've been talking about today. So now, and we start at 9 o'clock tomorrow, 9 o'clock tomorrow. And I want to invite you now to the third floor for our reception. It's for those of you who ate lunch up there, you know the way. For the rest, follow them. So we'll see you up there.